Let's see, we're good. Hi, for those who don't know me, I'm Jeff Wallace, professor in the Division of Geriatric Medicine. I have the privilege and honor of introducing our Grand Round speaker today, Dr. Douglas Powell, who's a professor of internal medicine at the University of Washington in Seattle. The reason I'm the introducer is because, for anyone, it doesn't matter, but I have been the co-chair of a clinical excellence group called Excel for the last half dozen years that has been reinvented as the Clinical Excellence Society. And the whole mission is on campus to recognize, promote, celebrate clinical excellence. And that, under the direction of Dr. Chopra, has started with its first round of inductees this year. And one of the things that we hope will continue is we've nominated a speaker who really embodies clinical excellence. And there's no one that I can think of and know as a colleague who does that better than Dr. Powell. So Dr. Powell began his journey at Macalester in Minnesota for his undergrad. He went to Michigan for his for medical school and excelled there and started getting lauded for teaching and clinical excellence even in med school. Went off to UW in Seattle for internship, residency, and chief year, and stayed on faculty. He's been at UW ever since. In the many hats he's worn there, he's been their clinical clerkship director for medical students, directing many a person into primary care medicine. For anyone who knows, he sent a ton of medical students our way who've excelled in our residency program, many of whom are still on faculty. So we thank Doug for that. He was a head of the GIM division. His national and international teaching resume is very long, and I'll just say he's had over 40 visiting professorships in the country and outside of the country. His publications are 150 plus. His book chapters are 60 plus, and his list of honors, and they're primarily for clinical care, but also being recognized for teaching by this many national organizations, is, again, number 40 plus. So I would look and say the other thing that I've just seen Doug do over the years with the National Board of Medical Examiner, helping them with their certifying test, helping MICSAP with all of you certifying and recertifying, and being an active speaker at the American College of Physicians for 20 plus years. At the bedside, there's nobody better. I'd send everyone I could to him. His compassion and empathy with his patients is amazing. His dedication. Too many patients have his cell phone number, but he still answers it, and has just been an incredible critical thinker. Whenever a tough case comes up, they look to Dr. Powell. So for the Excel group, we look to him, and he kindly agreed to speak today. So I will end there, turn over the podium to Dr. Powell. Thank you for being here for Medical Grand Rounds.
Thank you so much, Dr. Wallace. I really appreciate being here. As Jeff mentioned, we've sent so many of our medical students here, and they've gotten such amazing training and great experiences. And we just really think so highly of this program and this institution, and I'm just very honored to be here. My talk today is a topic that I've been very excited about since the mid-90s. And when I was a medical student, I just always got frustrated when people would hit me with dogma, like, this is right. And then I realized when I was a resident that I was the same person. You know, I'd remember something and I'd go, you got to do it this way. And then I started to see that sometimes the ways we're taught aren't always the only way. I love internal medicine because there's so many right paths in internal medicine. There's usually not one way to do things. But what I'm going to do is go through things throughout the 30-some years I've been doing this, and things that I talk about as medical myths, but they're usually more dogma, and when we push things one way, and are there other ways to do it? So why did these occur? One that we'll touch on some of these is physiology that just makes so much sense. We're taught a physiologic explanation of something in medical school, and it sticks with us, and we are told that's the only way to do it. Another real common way for this is case reports, that things get into the literature quickly with case reports, and they don't always get the same scrutiny, certainly not the same as randomized controlled trials or other type of research. You know, where case reports are just one-offs, and sometimes that becomes the dogma. And then the other one is tradition, which is something that's never been studied. And so I'll break these down into older myths, myths of tradition, and things that we kind of deal with every day. So let's start with some really old myths. And some of you are going to go, why is he even talking about that? We know that's wrong, but I'm hoping that everybody will find something here that surprises them in this talk. So here's our first case, and I want you all to get some exercise by raising your hands on what you would do, not like what is the right answer, but what would you do? Because there may be multiple right answers. An 82-year-old woman is evaluated for fatigue. Lab eval reveals a hemoglobin of 8 with an MCV of 114. A B12 level is 90 with the lab limit of normal being over 200. Folate level is normal. Urine methylmalonic acid level is high. What would you recommend for this patient? Oral B12 1,000 micrograms a day, blood transfusion, then IM B12 monthly, or an IM B12 load, then monthly B12 injections. How many would start on oral B12? How about blood transfusion and then IM B12? How about IM B12 load, then monthly B12? So kind of a mix, and I like to see that. That's great. And I would say A and C are both right. You can certainly give her IM B12, and that would work. Oral B12. I'm not sure she really needs a blood transfusion here, but let's go through. And what I want to talk about is this is certainly what I learned in medical school, that if you don't have intrinsic factor, if you have pernicious anemia, you're not going to be able to absorb B12. And the only way you're going to get it is if we bypass the stomach, if we inject it. And that, when I came into practice, that's what everything was going on. And that has continued quite a bit to today, even though there have been studies dating back to actually the 50s. I'm going to show you a study from 1968 that looked at what if we just give these pernicious anemia patients oral B12. This was a study that was published in Acta Medica Scandinavia, and it was from Sweden. It's not a surprise because we know there's more pernicious anemia in individuals from that part of the world, but 64 patients with established B12 deficiency from 3 Swedish medical centers were given either 500 or 1,000 micrograms of B12 every day. All 64 normalized their B12 levels, and all of them recovered their anemia. Nobody got any neurologic problems, no problems over about 6.5 years of follow-up. So oral B12 worked in everybody in this study, and this was immediately forgotten. Nobody cared about it. Why is it? Well, we had no internet in those days, and not everybody read Acta Medica Scandinavia. This didn't make it to the New England Journal. It didn't make it to things that, at least in the United States, were a big deal. So this was kind of a footnote. It was kind of there in the back. Until the 90s, when another study was done, and again, small number of patients, but 38 newly diagnosed B12 deficient patients were assigned to get IM B12 or 2 milligrams orally daily. It was the 90s, so we had to do bigger and better. 1,000 worked plenty. It gave super high levels, but let's give them 2,000. Why not? So these patients had B12 levels tracked. Methylmalonic acid levels were also measured to see if it was really clinically and biologically important B12 deficiency and how that was going. And they found that the IM B12 group normalized, as we would expect them to. They went up to a nice normal level. And the methylmalonic acid levels came down to normal levels, but the oral B12 group actually had higher levels. The 2,000 micrograms got people to an average of 1,000 picograms per milliliter, very, very high B12 levels by giving them the 2,000. And their methylmalonic acid levels came down even more. So not a lot of studies, but it seems to be working. I've been doing this since the early 2000s. It's been very, very, very effective in pernicious anemia patients. The other question comes up, okay, well, not all my B12 deficient patients have pernicious anemia. How about my post-gastrectomy patients? Here's a small study that showed that it's okay with post-gastrectomy patients too. And normally I'm not overwhelmed by small studies, but one of the things about B12 deficiency is it's pretty easy to track, right? We give them the B12, they've had a gastrectomy, they come back in 3 months or 6 months, and you can recheck their B12 level and see if it's in the normal range. So we can actually follow this pretty safely and easily. Here's the Cochrane review that was published in 2018, and they cite low quality evidence shows oral and IM B12 having similar effects in terms of normalizing B12 levels, but oral treatment costs less. And again, this is something that because we can follow it so easily, I think it's a very, very, very reasonable thing to do. Just now you're going, well, why does this work? Okay, these studies show it works. Well, what we're taught is when we eat small amounts of dietary B12, like we all get in our diets, we need to have a really effective system to absorb it. So intrinsic factor allows us to have a very efficient system of absorbing B12. But heck, we can overpower that by giving massive amounts, and there can be mass action that can bring in some B12. So there's both intrinsic factor dependent and independent absorption, and the high doses that we give people for treatment of this has its own mechanism that works. 500 to 1,000 works fine. 1,000 is just fine. 2,000, they'll pee off the extra B12 if you want to use that. And we can use it in gastrectomy patients. We can use it in pernicious anemia patients. Certainly, patients whose small bowel have a major problem. People have had major resections, missing a lot of their small bowel. This isn't going to work. But for the people with the main problem is in the stomach, it does work, and it's extremely cheap. Okay, here's another really old one. A 32-year-old man is diagnosed with Giardia and prescribed metronidazole. He has no other medical problems. He will be the best man at his brother's wedding tomorrow. What advice should you give him about alcohol use at the reception? Do not take metronidazole the day of the wedding if you will be drinking alcohol. Take metronidazole, don't drink alcohol, or it's okay to drink alcohol. So what should we tell him? He's asking you because he's got a pill bottle that has a big X through a martini glass on it. Okay, how many of you say, just don't take the metronidazole the day of the wedding if you'll be drinking alcohol? How about take the metronidazole, don't drink alcohol? How about it's okay to drink alcohol? Yeah, so this is one that's still, to this day, if you prescribe metronidazole, that little X will go through the little martini glass on the pill bottle. So it's still, the pharmacists have not bought this. So the dogma for this is that we have advised patients that they shouldn't drink alcohol when they're taking metronidazole because of concern for a disulfiram-like reaction between the alcohol and metronidazole. This has been the standard warning that's been there forever. So where did this come from, and do we have any evidence that it's not true? So this is one that case reports really got this to be proof. So back in the 50s, metronidazole actually was used a little bit as a disulfiram-like drug with the idea that maybe this is something that happens. There's some pharmacological texts that talked about this. And then there were case reports that said, absolutely true. When people drink alcohol and they get metronidazole, they get sick. And found 8 case reports. 4 of them were severe. But the problem with all the case reports is none of them look at acetaldehyde levels. None of them look at blood levels. They just described all the symptoms. Now, I think you're all aware that alcohol can make you feel pretty sick, and metronidazole can make you feel pretty sick. Metronidazole has a lot of side effects, nausea, vomiting. Certainly alcohol can too. And so the ability to say that these two were an interaction between the two was not proven in any of these case studies. Well, animals are good options to look at. Rats are pretty good to study. They don't complain a lot. And if you offer them alcohol, they like you. So this study went really well. And I'm just going to skip over this. I meant just talk about that. In the rat model, they found that there really was no drug interaction in the blood between alcohol and metronidazole. But interestingly enough, and not surprisingly, metronidazole is going to change the GI flora. And by changing the GI flora, there was more Enterobacteriaceae that was growing out because metronidazole didn't affect that. And that's an alcohol dehydrogenase containing aerobe, which they thought maybe that could affect acetaldehyde levels in the gut, but not in the blood. They didn't find any of these rats that it went into the blood, and it was certainly not an interaction. Thought, well, maybe, just maybe, that could cause a little diarrhea or something, but it couldn't cause the systemic reaction these individuals had. So what do we need? We need a randomized controlled trial, right? So this is a randomized controlled trial, tiny, 12 healthy participants. Where do you think you can find 12 healthy participants who will be happy to get free alcohol and money? Any guesses? Medical school. Well, I always say it's WSU because I'm from the University of Washington. You know, WSU is big party school. So no, this is a medical school, medical students who are happy to do this. And they did it well. They took half of the patients and they gave them metronidazole for 5 days, which I'm glad they did, because if there's any issue with microbiota that's a part of this whole thing, they had it for several days. They didn't just give them a dose and then some alcohol. The other half got placebo, and then everybody got the promised alcohol. They were watched very closely. They kept a symptom diary, and then they had blood tests repeatedly to see if any of these numbers changed with the alcohol and the metronidazole. And they found there was no difference in blood acid aldehyde levels, vital signs, or any symptoms these individuals had. So this is all we have as far as randomized controlled trials. I will put the caveat, these were healthy medical students. These were not people with end-stage liver disease and got a combination, but this did not show a drug interaction between metronidazole and alcohol. In the 2021 STI guidelines, they have put this in there as that this is not something we should worry about. The previous warning against simultaneous use of alcohol and metronidazole was based on lab experiments and individual case histories in which the reported reactions were equally likely to have been by alcohol or metronidazole, and that it does not inhibit acetaldehyde dehydrogenase as occurs with disulfiram, and that refraining from alcohol while taking metronidazole or tinidazole is unnecessary. I will say that I wrote a column on this, and I put my little email address, and it said that I was the medicine clerkship director, and I got some emails back from people saying why they let you teach medical students when you are such a proponent for alcohol is beyond me. I just want truth. People can decide whatever they want to do, but if we don't have data for things, we should rethink it. How about this one? A 30-year-old woman cuts her finger on a glass jar. She goes to the ED and needs to have sutures on her right ring finger. What would you recommend for anesthesia to prepare the patient for repair? Bupivacaine, 1% lidocaine, 1% lidocaine with epi, lidocaine 2%, or saline. So how many want to go bupivacaine here? How about 1% lidocaine? How about 1% lidocaine with epi? How about 2% lidocaine? How about saline? So I think the right answer here is lidocaine with epi. And my goodness, that was something that was drilled into me in medical school. Never do that. When I was on my ED rotation, I'd heard it on my family med rotation. Then I went to ED, and it was like, you're going to do a lot of suturing. Whatever you do, don't do this, or people's fingers or toes or other parts of their body will fall off if you do that. So the idea is that you never want to use epinephrine in an end arterial field because it might cause vasospasm. It will could cause ischemia, could cause necrosis, could cause a lot of problems. That's what we were all taught. How many of you were taught that? Yeah, I think most of us, we heard some version of that. So there is one randomized controlled trial here. And it was a well done study, 60 digital block procedures, 31 randomized lidocaine with epi, 29 to lidocaine. Lidocaine with epi, 1 patient needed additional anesthesia. The lidocaine alone, 5 did. Digital tourniquet was needed in only 9 of 31 of the lidocaine with epi and 20 of 29 in the lidocaine alone. So they're getting some ischemia with their digital tourniquet. 2 people had complication after lidocaine, none with lidocaine with epi. Tiny study. Probably is not going to sway everybody's minds, but this is more impressive to me. It's like, what do our hand surgeons do? What do the people who do this day in and day out, and that's their livelihood, do they use lidocaine with epi? Because it certainly is nice to not have that a lot more bleeding. It makes it a lot easier. So this was a prospective study looking at the incidence of digital infarction and phentolamine rescue in a large series of patients who received epinephrine in their fingers and hands. From 2002 to 2004, 9 hand surgeons prospectively recorded each consecutive case of hand and finger epinephrine injection. 3,100 consecutive cases of elective low-dose epinephrine in hands and fingers. No cases of digital tissue loss, infarction, anything, and they never had to use phentolamine. So I've been talking about this for a long time, and one time I had a podiatrist in the crowd, and he comes up and goes, "We've been using lidocaine with epi in the toes forever. We would not give it up. I mean, trying to remove a nail or something, it bleeds like heck." And he pointed me to this 1971 study of 18,000 patient records over 14 years reviewed. Additional 5,000 records from the author's practice, was a podiatrist spanning 27 years in foot surgery patients. All were deemed healthy. 65,000 digital surgical procedures reviewed that used lidocaine with epi, no complications due to epinephrine. I have also seen case reports of people that injected an EpiPen by accident into the palm of their hand as they were freaking out, as they were having an allergic reaction, discharging into their hand, and there was no necrosis occurring with that. Literature review, 39 studies of epinephrine digital blocks in fingers and toes, no digital necrosis or gangrene in any patients. Okay, we're going to move on and talk about a few myths of tradition. These are just the things that you've been told, and let's see if there's any evidence behind them. A 51-year-old man, status post bowel surgery for diverticulitis 2 weeks ago, presents with pain and swelling in his right leg and is found to have a DVT in the right femoral vein with a clot extending 20 inches. He has started on anticoagulation. What other recommendation is appropriate? An IVC filter, activity is tolerated, bed rest for 3 days, or bed rest for 7 days. So how many people want to put an IVC filter in? Good, that myth is dead. What good is an IVC filter? Activity is tolerated. Yeah, good. So this one has made it mainstream. Certainly when I was in training, these people with the huge clots, they were told to just lay low, because if they moved around, they might dislodge the whole clot and something terrible would happen. And that made a lot of sense. I mean, from a physiology standpoint, you don't have the muscles squeezing, and what if we knock that clot loose? But it has been looked, and the data is, they can move around, as all of you would recommend for this patient. Meta-analysis of 5 studies, including 3,000 patients. Bed rest versus ambulation, not a higher incidence of a new PE with a relative risk of 103, confidence intervals crossing 1. And patients who did early ambulation had a trend towards less pulmonary embolus and less extension of DVT and a lower mortality. So I think this is one of those things that maybe we were taught a long time ago that has some proof, and we've moved and we've adjusted with it. A 58-year-old woman with a history of right breast cancer, status post lumpectomy and lymph node dissection 5 years ago presents for follow-up. Labs are ordered and left arm blood draw is attempted ×3 without success. What do you recommend? A left leg blood draw, a left neck blood draw, a left radial artery draw, or a right arm blood draw? So how many of you would do a left leg blood draw? How about a left neck blood draw? How about radial artery? How about a right arm blood draw? Yeah, so you all know what to do, but the problem is going to be the patient's going to fight you on that. You're going to have to spend a lot of time counseling the patient, because the patient has been told, don't let anybody touch that right arm under any circumstances, and that includes blood pressures. How many of you had that experience where you try to do a blood pressure? No, you can't do this arm. So is that true? Do we have any data that says protecting that arm will prevent lymphedema? So the classic teaching has always been avoid blood draws, any injections, blood pressure readings in the at-risk arm during or after breast cancer treatment to reduce the risk of cellulitis and development of breast cancer-related lymphedema. So that's the teaching that's out there. This is from the American Cancer Society website last night. If the lymph nodes under your arm were treated as part of the treatment for cancer, some doctors recommend having blood draws, IVs, shots done in the unaffected arm if possible. Some also recommend getting flu shots and other vaccinations in the unaffected arm or somewhere else like the hip. So even the ACS still, it's on their website. I am happy that they say some doctors. They don't say all doctors. So what data do we have? This is a study looking at what happened to people who threw caution to the wind and just like treated both their arms the same, and they didn't do avoidant behaviors. They looked at patients undergoing treatment for breast cancer between 2005 and 2014, and they were screened for lymphedema, 3,000 measurements, no association with volume change or weight adjusted change, increase in undergoing 1 or more blood draws, injections, or blood pressure measurements. So they asked the patients, do you have stuff done in the affected arm? And those who said no were one group, and those who said yes were the other group, and they found no difference between the groups whether they did precautions. And those non-precautionary behaviors, 251 of the almost 3,000 patients had 1 or more blood draws from that arm, 63 had 1 or more injections, and 482 had one or more blood pressure measurements. But what this shows you is, again, most people are not doing that. They are avoiding that arm. And what do I do with this information? If my patient needs that arm for something, and especially blood pressures, we need to check that, I will reassure them. I don't try to tell them, no, you must treat both your arms same, because they're very invested in that and they've lived their life that way. But if we need it, I try to educate them on that. And sometimes it works. Sometimes we just move on and let them continue to not ever have a blood pressure in that arm. So here's another study, 2013, 2016, 327 patients who underwent bilateral breast cancer surgery prospectively screened for arm lymphedema. Cohort was 327 patients and 654 at-risk arms with a median postoperative follow-up that ranged from 6 to 68 months. Blood pressure readings, blood draws, and injections were not significantly associated with increased arm volume in this cohort. So this was another study looking at it that was a little bit more prospective. Okay, we're going to move on to some of the things, sort of what I call everyday myths, don't really fit in the super old myths. Some of these are a bit old, and they aren't pure myths of tradition. A 55-year-old patient of yours requests new prescriptions from you at a routine appointment. She will be traveling internationally next month and wants to replace her emergency medication kit as the medications in it, azithromycin, loperamide, oxycodone, have all expired. What do? Replace the prescription for azithro, replace all 3 meds, or tell the patient all the meds should still be fine. How many of you want to replace the azithro? How about all of them? How about tell her that should be fine? Yeah, I like C, and we'll go through some of the data. I mainly like it because I really hate emergency medicine travel kits, because I feel like I gave advice out in the 90s and my patients still believe it. Like most of the stuff's evolved. Whatever I gave them then, I probably am not prescribing now. But this is so interesting, the issue of how long, especially with PRN medicines, are they potentially good for? Can they be toxic? All those questions come up. And the expiration date is purely something the manufacturer is required to do to prove that they have 90% potency. But pharmaceutical companies do not go out 3, 4, 5, 6. They just pick a date, they prove that's a potency date, and that's what their expiration date is. So we don't have a uniform idea of how long medications last. So let's look backwards. And this is a study called the Shelf Life Extension Program. This study was funded by the US military because they have a very big vested interest. They have to have lots of medications for the troops, but they also are in charge of, if we have another anthrax scare or something that we've had before where we need to have medicine for our whole population. And if you can extend the shelf life of large amounts of medicines instead of just throwing them away, that's a huge financial benefit. So they looked at 122 drugs representing over 3,000 lots of drugs. They found 88% with over 90% potency 1 year past expiration date, with the average extension being at least 5 years. A couple of examples: ciprofloxacin, 55 months that they still had over 90% potency, doxycycline, 50 months. So antibiotics still stable there. This is a much more interesting article to me. This is when they forgot and lost the drugs and then studied them 40 years later. So this is stuff from an old mom and pop pharmacy where they had an old storeroom, and they finally kind of cleared out, wait, what's this stuff from the 70s? And they found things that were 28 to 40 years past expiration date. 12 of the 14 of them were compounds that had, some of them had multiple drugs. This was the heyday of fiorinol, fioricet, all these combination drugs. So there was little acetaminophen, some aspirin, some barbiturate, narcotic, a little bit of good stuff just mixed in there. So they got a lot of things they could study. They found codeine, hydrocodone, acetaminophen among the medications that retained their potency and didn't lose their potency over 40 years. The only thing that broke down was aspirin. Aspirin, they really couldn't find any evidence of it. It was less than 1%. So the aspirin was actually breaking down. But this is helpful for me with my patients to say, I'd kind of like to, I want to replace my oxycodone from, 2010. It's like, now you just, if you want to keep it there for, a rainy day or something, your 6 tablets of oxycodone, just keep it. It's too much of a pain to prescribe it anyway. I have to go through the whole everything I have to do for that. And I certainly don't want to give it when somebody doesn't have an indication for it. So this data is like, hey, it should still be good. Now, a lot of questions come up about how about liquids? The pill forms we can kind of see might be a little bit longer lasting, but how about epinephrine? We all know epinephrine isn't cheap, and is there a way that people can extend the expiration date for that? Well, what do we know in the literature? This is a study that looked at epinephrine remaining sterile and detectably pure more than 2.5 years after expiration. Another study, EpiPens less than 25 months past expiration contained at least 90% of the labeled amount. And this last study was a study of healthcare workers who turned in their EpiPens and EpiPen Juniors that they had in the car or the glove compartment or at a cabin, just under all sorts of temperature issues that could be going on. They just had an extra one. And they found 1 to 50 months past expiration all had over 80% of labeled concentrations. So what do we do with this information? And what I advise my patients is, I think epinephrine's a high risk thing, right? It's like if people need their EpiPen, they need their EpiPen, and we want to have a 0 chance of a problem with it. What I tell them is, I'm not sure that you should toss all your other EpiPens the minute they hit expiration, because I'd rather have you have 3 EpiPens around than just your one go-to EpiPen. So know where that is, have that close to you. But if you forget, you got one at the cabin, you got 4 in the house, or if you collapse in the bathroom, you can crawl into the bedroom and still get it, because we don't have to toss these right away the day after they expire. Now, other questions are, how about inhalers? How long are they good? And this is a study that's just published a couple of years ago, which is something I think we've all suspected, that we think they probably continue to work. I have patients that have an inhaler, from the Carter administration, and they're still using it, So this was the one looking at samples of expired lots of albuterol analyzed for their level of active ingredients, and they did a nice liquid chromatography study. Manufacturer expiration dates ranged from March 2001 to April 2019. Nearly all lots of albuterol remained over 90% of listed strength over 15 years post-expiration. So they found for at least a decade after it expires, they were finding that these things still had the predicted amount per inhalation of the active product. Now, another question comes up, how about toxicity? Could I kill somebody with an expired drug? Like if they take a medication that's 70 years old or 50 years old or 30 years old, could it be toxic? And really the only medication in pill form or capsule form that showed any toxicity was an old preparation of tetracycline that went off the market, I believe, in the early 1980s. There were 4 case reports of Fanconi syndrome occurring in those patients who took this very outdated tetracycline. That formulation is off the market, and there haven't been other case reports of pill drug toxicity. So the worst case scenario with expired pills is probably lack of efficacy, and we don't think that is for many pills. A 46-year-old man who lives in Tacoma, Washington is seen for fatigue. He has no significant past medical history. He's not taking any medications at all. His labs, hemoglobin 12, hematocrit 37, MCV 103, TSH 1.2. So this guy's got an MCV of 103, crit of 37, so just right on the borderline there for him. Otherwise, being a little tired, otherwise he's fine with no medical problems. What workup do we recommend for him? B12 and folate testing, alcohol history, B12 folate testing, or alcohol history and B12 testing. So how many people would do B12 folate testing? How about a good alcohol history, B12 and folate testing? How about alcohol history and B12 testing? Yeah, a lot of you are kind of on the let's be careful with folate testing bandwagon, and I agree. So I would do C. I mean, I was taught in medical school, and it's in my brainstem, and someday when I'm in a nursing home peeing on myself, I'll still remember B12 and folate and everybody with a high MCV. But times have changed. So in the United States, before 1998, before we had fortification of grain products, we did see not rare folate anemias in the right patient population. We certainly would see it in people with alcoholism before fortification of grain products. Fortification with folate, we would see it. But since that time, it's become incredibly rare. And really, we shouldn't be doing folate as our first step when we work up an anemia, first step when we work up a little bit of an MCV bump. We have data on this, yes. So this is 2 teaching hospitals in Canada. 11 of 2,100 serum folates were low, and 4 out of 560 red blood cell folates were low. No subject with low folate could the anemia be ascribed to the folate. They found other causes, and they didn't believe that it was a folate deficiency anemia. A bigger study looking at 84,000 folate levels measured in 7,600 individuals. They found 0.056% were deficient, 166 low normal. And again, none of the anemias that these were drawn for or the high MCVs turned out to be due to the folate. So the American Society for Clinical Pathology said, certainly don't get red blood cell folate levels, and really to think strongly about when you choose to order folate in an anemia workup. It really shouldn't be in the very first wave. So, but what should we think about when we see macrocytosis? So when I talk to lots of people, and certainly with our students and trainees, the first thought is B12 and folate. And when you get a significant macrocytic anemia, like the 114, sure, the B12 is likely, but you're going to see so many more patients that have alcohol use that are bumping their MCVs to 100 or 101. And this study, looking at 300 consecutive primary care patients with MCVs over 100, 4.7% were anemic, 80% of the men, 35% of the women, the cause was alcohol. And so no anemia with a little bit of an MCV bump, it's extremely likely it's going to be alcohol. That's going to be the most likely thing. As people get older, other things creep into the differential. So myelofibrosis certainly can do that. I see a lot of my 80, 90-year-old patients where that's the cause for their little bit of an MCV bump. But in the non-anemic patient, certainly think about alcohol. 29-year-old woman presents her evaluation. She reports that she's had frequent headaches over the last 12 months that include pressure pain on her forehead, under her eyes, and over her cheeks. She usually has nasal congestion as well. She has not had any fevers or purulent nasal discharge. What is the most likely problem? So, young woman who has had headaches over the last 12 months, pain, forehead, under her eyes, and over the cheeks, nasal congestion, not any fevers or nasal discharge. What has she likely had? Cluster headaches, migraine headaches, sinus headaches, or tension headaches. How many people think cluster headaches? How about migraine headaches? How about sinus headaches? How about tension headaches? Okay, so yeah, so this is super common. I saw one of these in clinic on Monday. And the right answer here is this is a really common variant of migraine headache. And it just seems to be one of those things that never got traction. There are a bunch of studies about it. It's in headache guidelines, everything, but it just didn't get to us. I don't know why, because we have people who come in several times a year going, I got another sinus headache, can give me decongestants. God forbid they ask for antibiotics. They often do for this, but they're migraine headaches. And let's go through. So this is a study of almost 3,000 patients screened who reported at least 6 headaches during the previous 6 months, self-diagnosed or physician-diagnosed with sinus headaches. 88% of these patients met International Headache Society criteria for migraine. Most common symptoms of patients reported were sinus pressure in 84%, sinus pain in 82%, and nasal congestion. So it's understandable why we think these were all a primary sinus problem, but it's actually a migraine that's causing all the symptoms, that the second division of the trigeminal nerve gets activated, causes the pain. They can get a little bit congested with it. Another study, similar types of findings, 100 patients believed they had sinus headaches, all received detailed history and physical exam, given a headache diagnosis based on the International Headache Society criteria. Final diagnosis, same numbers. Migraine with or without order, 52%, add another 23% probable migraine, and then chronic migraine, 11%. So you're up into around mid 80% were migraine headaches. 76% of the migraine patients had pain in the distribution of the second division of the trigeminal nerve, and 62% of them had bilateral forehead and maxillary pain with their headaches. So this is why we don't think of it. We're always taught unilateral with migraine. This variant can have bilateral. So it's understandable we don't think about this. This is a study to show how long it takes to make this diagnosis. This included migraine patients with a past history of sinusitis. Total of 130 migraine patients were recruited. Of these patients, 106 were misdiagnosed as sinusitis. The mean time delay of migraine diagnosis was 7.75 years, range 1 to 38 years. So really the myth here is sinus headaches, and certainly acute sinusitis can cause headaches, but the idea of sort of short-term little sinus headaches that people get recurrently, more likely than not, it's going to be a migraine variant. I like this study. This was a treatment study, and some of what happened in this study is what I've experienced as well. This is a study to look at seeing if triptans alleviate sinus headaches in patients who had normal endoscopy and normal CTs of the sinuses. So they recruited 54 patients who believed they had sinus headaches. Their physician believed they had sinus headaches. They went, they got CTs, they were normal, they did an endoscopy, and then in the sinuses, those were normal. And they had a big dropout rate. 16 people quit the study after they were told they didn't have sinus problems because they believed they did. So they just left. They said, I'm not getting care from people who don't hear me and understand that I truly have a sinus problem. 38, and I certainly have seen that a lot as I try to explain this to my patients, 38 of these people were brave and said, fine, I just want to feel better. So they were getting treatment, and 31 of those patients had a great reduction in headache with triptan use, and 35 of the 38 had a response to migraine-directed therapy. So 90% of these people responded to migraine-directed therapy. So I think this is worth a try. I saw this patient on Monday, and he wanted to talk about, never talked to you about my sinus headaches, and he is a guy with a long migraine history, and I think that's what it is. I'll see if it helped him, the triptan I gave him. A 59-year-old woman is admitted for abdominal pain. She has a history of pancreatitis. A contrast CT scan is ordered. She reports a history of severe shellfish allergy and an allergy to betadine when the radiology tech asked as she is checked in for the procedure. You are paged regarding what to do. So you want your contrast CT, and they're saying, well, you know, she's got a couple allergies here. So A, continue with the scan as ordered. B, switch to an MRI. C, switch to MRI with gadolinium. D, continue with CT with contrast, but give a dose of solumetrol. Or E, continue with CT with contrast, give IV diphenhydramine. So how many would do A, continue with the scan as ordered? How about B, switch to an MRI? How about C, MRI with gadolinium? How about D, go ahead with it, but give a dose of solumetrol? How about E, go ahead with it and give some diphenhydramine? Okay, so the right answer here, a bunch of you chose A, which is absolutely correct. And this is something that's still out there, and it's still out there among the people who give contrast a lot, which surprises me. So this myth came from fish and shellfish and betadine. They all have iodine, and allergic reactions to seafood are quite common, with a prevalence ranging from 2 to 6% of the population. You may have up to 2% of people that will cutaneously react to betadine, which has iodine in it. So those are iodine allergies. So, oh my God, we better not give iodinated contrast media, right? Well, the problem is the allergy isn't iodine. So who cares about iodine, right? So iodine is present in lots of foods, and we don't ask about that. And the allergy to shellfish is due to 2 different proteins that are in shellfish, and that's why they have allergic reaction. It has nothing to do with iodine. But belief is still pretty widespread. This is a study just from a few years ago, 2019, looking at this pervasive myth remained among emergency medicine and radiology providers. 20% of EM radiology physicians surveyed would not administer contrast to a patient with a shellfish allergy, and a majority, over 50% of the respondents, indicated that an iodine allergy limited ability to receive IV contrast or required pre-treatment. So if they had a betadine allergy, they would say the same thing. So what is really going on? So I think you all know the world is divided into 2 groups. People with no known drug allergies, and then the rest who, many of them have a lot of allergies, and they're just people that are very allergic. And those people are at a little bit of increased risk with a reaction when they get contrast. But their risk isn't higher if they have a shellfish allergy or a betadine allergy than if they have a milk, eggs, chocolate allergy, just general allergies, fruit allergies, asthma, or medication allergies. So they're all in the same ballpark, and we don't ask them about all of those things. Current guidelines support that we go ahead and treat these patients with contrast. The American Academy of Allergy, Asthma, and Immunology does not recommend low or isoosmolar radiocontrast media pretreatment with corticosteroids and antihistamines for patients with a history of seafood allergy who need radiocontrast. The American College of Radiology recommends pretreatment with steroids only for those who had a previous contrast reaction. How about betadine? What do we have about that? And this is from the American College of Radiology Manual on Contrast Media 2023, so recent. Patients with shellfish or betadine allergies are at no greater risk for iodine in contrast medium than our patients with other allergies. Neither is a significant risk factor, is their bottom line. There is no cross-reactivity between different classes of contrast medium. For example, a prior reaction to gadolinium-based contrast medium does not predict a future reaction to iodinated. So they say, yes, we're aware people have allergies. We're going to go ahead and treat them. And then if they have a reaction in the future, then they would be pre-treated. That makes it easier for us to do our tests. It's just the problem is, even though this is an ACR manual, I still get pages from time to time saying, they told us they have an allergy. Okay, I'm going to finish up by something near and dear to my heart, which is colonoscopy dogma, which is clear liquid diet for 1 to 2 days before colonoscopy, a gallon of Go Lightly, and be absolutely miserable. So starving a person for a couple of days, lots of something that's really, really hard to gag down an entire gallon of it and be miserable. Now, I will say that over the last few years, I've seen people moving away from the gallon of Go Lightly, but how many of you have had to be on a clear liquid diet or had patients who had to be on a clear liquid diet recently before colonoscopy? Yeah, I was seeing some hands. This is super common. The UW, they never let anybody do anything but a clear liquid diet. And there is incredible amount of evidence that the clear liquid diet is no better than low residual diet. Low residual diet, in this study, 200 patients randomized to get a low residual diet or a clear liquid diet. Low residual diet allowed meat, eggs, dairy, bread and rice. They can have, they can have all the milkshakes. They can have chicken. They could have a burger without, they could have all of that, fits in that through the day before colonoscopy. So they're not telling them to do clear liquids the day of. Patients in the low residual diet group had better bowel prep than those in the clear liquid diet group, less nausea, vomiting, headache, weakness, and hunger, and most importantly, more willingness to have a colonoscopy in the future. Here's a meta-analysis for low residual diet and clear liquid diet, comparable in regards to adequacy of bowel prep and detection of polyps, less nausea, vomiting, hunger, headache with low residual diet. So they were just as good as finding polyps, and there was not a lot of symptoms in these patients. And those who followed low residual diets showed an increased willingness to repeat it compared to those who followed the clear liquid diet. How about the different bowel preps? Is there a difference? Is there a reason to make people drink Go Lightly other than you don't like them? So lower volume bowel preps, there are a lot of them now. There's Suprep, Movie Prep, Miralax plus Gatorade. All of them were superior to Go Lightly for bowel cleansing. And I think the reason is people completed them. They can drink 16 ounces something, maybe 32 ounces, but drinking the big gallon thing is very, very difficult. Those taking all of them were more likely to complete the prep. So I think this just is good medicine to make it easier on our patients, make them more willing to get follow-up colonoscopies if they need them in the future, and make them less miserable. I got a message just 3 months ago. One of my patients with type 1 diabetes was saying, "What should I do the day before? They won't let me eat anything." I'm like, hell no, here's a long list of things you can eat, and you don't have to go into DKA because of this. So bottom line is let people eat. Low residual diets are tolerable and with less symptoms and work as well as clear liquid diets. And Go Lightly is really a relic of the past. All it has going for it is low cost, and now most of the insurance companies are covering the smaller volume preps. I think that's the last thing. I'm happy to handle questions for a little bit. If you have favorite myths of your own, I'm always interested in hearing about them. But thanks so much for your attention.
Dr. Powell, thank you. That was amazing. Maybe I'll start with the first question for the group. And I guess the question is, where do these come from? Right? Is this the catch up of evidence-based medicine that is now able to sort of replace what we thought was best practice back in the day? Or is there this intrinsic nature for us to try to explain something even in the absence of evidence?
It's both of those. It's definitely both of those. So, a good example is, and I think, and folks that are, my generation in the room, in the 80s, it was considered malpractice if you gave somebody in heart failure a beta blocker. It was like, that is the worst thing you can do. You're going to kill them. You're a terrible doctor. And then obviously we saw that there's a great role for beta blocks for people with systolic dysfunction. We learned about that. People with HFrEF, it's a very, very important thing. And so knowledge does evolve. And when we get enough studies, it gets mainstream and it evolves. But sometimes some of these things just don't get enough attention or maybe aren't as super common. The evidence base is there, but we don't have a great way of seeing it. And then, as you point out, a lot of it is things that haven't been studied before or things that were studied in an era. If you want to have fun, go back to look up articles from the 1940s and just read them. They're kind of fun. I mean, they're chatty, they're like, we were sitting around, we thought it would be a good idea to, look at this. And, the scrutiny of what we have to do to get studies approved, that didn't exist. So things are just kind of done left and right. And sometimes when you replicate some of those studies, you don't find what was originally found. And sometimes we just never replicate those studies because we had the answer in 1950. Yes.
Thank you. That was awesome. And I'm a gastroenterologist, so I appreciate all of the references to the GI stuff. Thank you for that. So the other thing that drives a lot of this is now patients.
I'm very hard of hearing. So I'll just come closer to you.
Okay, we can meet halfway. So the patients are driving a lot of this too, right? Everybody is Googling, everybody is Dr. WebMD. And how do we educate patients as to, what is myth and what is reality?
Yeah, thanks for bringing that up, because if you Google the top 10 myths, they will all be things that none of you in the room will think, well, that's definitely not, I know that. It's like, it's things that are just kind of out there and, sort of, tales that they got from their grandmother or something. So what I try to do is when it's important, I will explain, studies. I'll say, hey, there was this number of patients we did it this way. I don't think that's true, but I don't, I always look at the myths, the ones that are going to really impact their health. I'm going to die on that sword. The ones that are, like, okay, it's not going to hurt them if they keep doing that and they don't want to hear me about it. I think what's much more important is that we, teach each other so that our profession isn't propagating myths, but there's so many different myths that our patients bring out. And now we're getting even more misinformation on the web and even stuff, like I didn't go into it, like there's a whole list of statin myths out there, for example. So now we have to fight that when we want to put our patient on a statin is they might come with 4 things that they've gotten off the internet that have never been shown to be a problem. Other questions at all?
You have a question, Dr. Lessing? Okay.
Thank you. Can you hear me okay? Thank you so much, Doug. How do we fight the temptation to teach these things, especially this is what I know or was taught, so this is what I'm passing on to you? Any suggestions from your many years?
I think the problem is we don't know, I love the quote that, 50% of what you learn in medical school is wrong. The problem is knowing which 50%. And so we always don't know until we learn something new. Like I'm always shocked by the things I did for a number of years and I go, wow, that wasn't right. And then, so I think when we teach, saying, this is what I was taught is good. It's like, this is what I was taught. You're not saying that it's necessarily the last word on it. And then even, you know, sometimes as you meet with training, like say, you know, all this is evolving. And I always tell my students and my residents, like, you teach me, you keep me up to date on these things. When something comes out of my mouth that doesn't make sense, challenge me on it, because, you know, I might be propagating a myth and I'm just learning it now.
Dr. Powell, thank you. That was really wonderful grand rounds. Thanks very much.